Take two. I think Zainab's having some connection issues. So let's try that again, shall we? We're going to chat with Zainab tonight about some facial aesthetics and dental aesthetics as well. Quite quickly, Mike wanted me to sing a song, so I had to quit the last one because you definitely wouldn't want to hear that. Hopefully Zainab can sort the connection out. I don't know if Tadfi had these problems with when he was doing it from Harrow as well. But there we go. Get excited when I see that someone wants to join in when it's not Zainab. So sorry guys, at the moment it's just going to be me and Zainab. We might have a mystery additional guest again because we quite enjoyed that last week. Tavi says the Harrow area should do the lives from Fulham. It's not too bad down here. There we go. No signal anywhere in Harrow. Doesn't bode well, does it, bud? Yeah, we might have to get Mike on to talk about the dentures for the first half of it until Zainab can find some signal. Dr. G. Sohal, how are we doing? Bear with us, team. Stephen, cheers for saying hi. Giving us something. Are you a GP or a specialist? So we're both dentists, actually. So we're talking from a dental and facial aesthetics point of view. I'm a general dental practitioner, and Zainab's general as well. But she's got obviously the facial aesthetics qualifications going as well. Hi Matt, how you doing? I missed the dental gym. We got Viraj on. Now we're in trouble. Viraj Patel's here. Fresh off his ITI reunion party today. We found Zainab's found some internet. There we go. We might actually get. There we go.
Hi. Sorry I'm late. I've been trying to find a place in the practice with good reception. How are you?
I'm good. Yeah, Tadfi said the reception's not too good around there.
No, it's not the greatest. I've been looking for the right room, so I'm here now. Can you see me and hear me loud and clear?
All good. How are you doing? Busy day?
Very busy day, yes. Just about finished all my records and now fully present and excited to chat about all this.
That should be good. So in terms of, we had a question earlier just before you joined in about GP, specialist, that kind of stuff. So just a little intro about yourself and why we're going to talk about dental and facial aesthetics today.
Sure. So I'm a dentist by background, as many of you will know, qualified in 2010 from King's and worked for the NHS for the first 5 years. And in that window of time, I was exploring what path I wanted to take. Found quite early on that I loved aesthetic dentistry, pursued some training in aesthetic dentistry. So I did a year-long aesthetic dentistry course. And in that year, I was introduced to facial aesthetics, explored that a bit further. Didn't think it was something that I was going to love, but when I went on the course, absolutely fell in love with it and realized that really I loved the same things about facial aesthetic were what I loved about aesthetic dentistry. And I was for a little while torn between the two, but really determined to learn more about facial aesthetics and do it well, and do it safely, and do it kind of really step by step in a measured way to really do it safely. And I did that, and the more I did, the more I loved it. Got to a crossroads where I was doing sort of equal amounts of both and thinking about which path to take, and thought, wait a minute, these two work well together. And patients are coming in asking me about both. I can see where, how we can think with both hats on. Mm-hmm. Decided that I would continue with both, except that the dentistry I would do would be of a particular type. So I pursued only aesthetic dentistry. and here I am, and that's what I do. I have a practice in Northwest London, Harrow on the Hill, with my husband Ahmed, who you know. And we rebranded this practice to be facial aesthetics and cosmetic dentistry. We have a great team. Dr. Ted Fee is part of our team. I think, did you say he was on it?
He's here, yeah.
He was here today. He only left about an hour and a bit ago, I think.
Oh, he could have stayed.
Yeah, I love facial aesthetics, which is why I thought this would be a great topic when you mentioned. And with what you do, I thought it would tie in really beautifully, because we're able to now speak about how, you know, with dentures in particular, how you can influence lower facial aesthetics, so the lower facial rejuvenation. And I think that can often be overlooked. It can be overlooked when facial estheticians are thinking. And I think when we're thinking just dentally, the facial aesthetic element of how we can do anti-aging in the lower face can be overlooked. So here we are, we're able to talk about both, and I'm really excited about it.
Perfect. So you said right at the start, I want to rewind back to that. So you're doing the MS, was it the aesthetics MSc at King's or something similar, or?
No, I didn't do a master's. I took very much the practical route. So that 1 year dentistry course I did was a year-long course with Tipton.
Yep.
Tipton had me at the time. That was 2012. And that really just gave me a broad overview of dentistry, of aesthetic dentistry, split up once a month in Manchester, once a month over, you know, quite a lot of topics. But it gave me an insight into what I needed to do next and where I needed to focus my energy. I really like the sculpting side of aesthetic dentistry, and the really minimally invasive side, which is what took me quite heavily towards composite bonding, composite veneers. And then, of course, you know, thinking in a more of a minimally invasive way, and thinking long-term, these treatments needed orthodontics, so pursued orthodontics, more short-term ortho, and did several courses in short-term ortho, so Inman aligner, fast braces, 6-month smiles, and finally Invisalign, and found that actually Invisalign, so I've done all those and treated my patients with a lot of them, but found that for me, Invisalign was a really predictable way of achieving what I needed to achieve, that patients really got on well with. So that's what I do a lot of now. So I do a lot of the align, bleach, bond type cases, and minimally invasive porcelain veneers.
So the facial aesthetics view has always been sort of part of the armory, rather than, as you say, you sort of at a crossroads, but it was never the sort of thing. Because a lot of there's people that, you know, that you know, my sort of similar sort of period now where they're just doing facial aesthetics, you know, so that was never sort of it for you. You always thought it was going to be part of the armory for the general aesthetics.
Definitely. I found that I couldn't turn my back on dentistry. I absolutely love it. You know, worked really hard to to make it, and you know, I just couldn't do it. Couldn't turn my back on it. And whenever I thought about it, I thought, why do I actually really need to entertain these thoughts? Because why not do both? It makes complete sense. It's, to be honest, a really the skill set's very transferable. And although, you know, it sounds so separate, it's really not, because when you're thinking smile design, you need to look at the face, and it should be really facially driven. So my eye is kind of always looking between the smile and the rest of the face and the smile. And it's not so compartmentalized as it sounds.
So are you having patients coming to you for specific facial aesthetic things and sort of mentioning dental stuff? Are you just or does everyone come and see you as a dental consultation? How does it work in your practice?
So a bit of both. So there's a combination. So either they will come in just for facial aesthetics, and then it's purely talking about facial aesthetics. But what tends to happen is, as they're going through their facial aesthetic journey, they will bring up their dental concerns. And lo and behold, we are now making a plan that's kind of dual facial aesthetics and dentistry. Or it can be completely the other way around. So they come in primarily for dental concerns. And typically as the Invisalign journeys are evolving, we're reaching towards the end, and they're thinking, well, now let's bring up, you know, and also think trust. They're building that trust with the dentist, and then they think, well, you also do facial aesthetics. You're very heavily involved in the industry. Let's talk about that. Actually, I really, you know, I've had this on my mind and that on my mind. So things kind of organically transfer between the two. And then there are people who actually come in and during the consultation say, I'm here for both. And then it depends really which one is their primary concern, and will choose to focus primarily on that in that visit. Often I mean, with dental consultations, it can be quite lengthy. We're looking at a lot of detail, going through lots of treatment options and so on. It leaves little time sometimes for facial aesthetic consultations. So I might then give a broad overview of what we can do with the facial aesthetics, but say, let's have another visit and discuss that a bit more. So every case is different, but yeah, it looks broadly like that.
And I guess from as you sort of said there, the dental side can be a bit broader and wider because you've got that same as you do with a cosmetic dental appointment. You're saying, well, we've got to get everything healthy first and sort that. Whereas there's not quite that side of it with facial aesthetics, right? It's more sort of you're going to sort of do that initial phase maybe, and then move on to that a bit later on. So
well, I have quite a conservative approach with facial aesthetics as well. Every case is different, but the reason I say that dental consultations can take longer is because there's so many teeth in the mouth, and sometimes we're looking at each tooth, as you know, depending on what we're dealing with. If there is a heavily neglected dentition or there's a lot of treatment, there's a high treatment needs, we're really breaking that down into a long session of talking about each tooth, and then we haven't even got past the health bit, and we're now needing to talk about the long-term definitive plans and so on. So these can take time, and sometimes it's a case of taking photos, taking x-rays, going away, doing a treatment plan, coming back. So every case is different, but it's the fact that in dentistry there's that minute detail and there's so many teeth, it's not going to be as quick as a facial aesthetic one. And actually with my facial aesthetic ones, they tend not to be quick anyway. As you can see, I get quite chatty. And I really like to take some time to understand patients, because with aesthetics, it's so much more than just a tick. Well, it's so much more than being just results driven. You really need to understand what the patient's motivations are, why now they're seeking that treatment. That can influence a lot about the treatment plan and the pace at which we're going to take it and so on. So I'd say they both take a lot of time. And this is why they're both quite demanding, and this is why they've both taken a lot of training, and why it is continuous training in both fields, because it's, as you know, constantly evolving as well. So yeah, but the consultations in particular can be quite lengthy.
So whilst we're talking trainer, those are the sort of the main questions that we had from people, I think, wanting to go into it from a dental point of view. I think one of the questions sort of, when can you do it? Is it something you can do as soon as you've qualified dentally? Would you recommend that? Is it something that you should be doing alongside, as you said, you did your 5 years in the NHS? What kind of timings and what does the training look like? Is there different ways of doing it?
Yeah, I think there's definitely no wrong or right about how soon to get into it. But my personal feeling and view about this is that having gone through 5 years of dental school, to then go quite soon into facial aesthetics can be quite distracting. It takes a few years to really get to grips with foundation dentistry, to really feel confident, to really develop those soft skills with patients, to really understand how to make decisions effectively and quickly. All of those skills as a clinician come in those first few years as a dentist. And facial aesthetics in particular needs a lot of those soft skills. So from the soft skills perspective, I found that it was really useful for me to have spent that time with my dental patients for a good few years first. Mm-hmm. But also, I was then not too distracted, and I was then in a position where I could actually choose to do both. If I had gone into it too soon and I didn't feel my dentistry was strong enough, I might have got quite distracted, left dentistry. So I think for me, when I went into facial aesthetics, it was 3 years post-grad. So it was while I was still working in the NHS that I explored facial aesthetics, went into that training, really spent lots of time on training. I became a course junkie. And it was only about 5-6 years into being a dentist and doing both that I realized my path. So, but in short, I would say my feeling is that it should be a step-by-step progressive thing. You're more likely to be equipped well to make the right decisions about your future if you've got more in your toolkit.
That's a really interesting point. As you say, it's quite easy to get excited by the new shiny thing and leave the dentistry, which you say you might have only just finished doing.
Yeah,
it's quite an interesting point. But you wanted to talk the aging face, or I guess you want to start with the lower third of the face. So what does that mean to you? And let's just go for it.
Okay, so there's two things. When we look at the lower face, we're looking at the aging process. And then we can also, we're looking, I mean, when we're thinking dental hats in facial aesthetics, we're thinking how the aging face happens and the impact of tooth loss or tooth wear on the lower face. And also we can be thinking with our orthodontic hat on our orthodontic assessments about skeletal malocclusions, skeletal discrepancies, upper and lower incisal relationships, and how that impacts lip position, how it impacts the chin in relation to the rest of the face, and the profile in balance. So there's so much from the dental perspective in our dental training that allows us to pick these things up quickly and treatment plan correctly. So if we're talking about, for example, this is where you come in so well, because you do so much in the way of removable dentures. That's kind of become your niche, and you're amazing at it. And you're amazing at showcasing it in a really new and kind of innovative way. And the case you shared yesterday is a perfect example of how, having lost that vertical dimension because of tooth wear and premature tooth loss, this impacted the support of the tissues, so the lips and the cheek, and even the way that the smoothness of the chin. So that the whole aesthetic of the lower third of the face was affected by the loss in vertical dimension, vertical height, essentially. So when we assess a face, you know, as dentists, we're trained to look at everything, but we're really focused on teeth and the smile and the soft tissues around the mouth. But if we weren't dentally trained and we were just looking at the face, we would be looking at facial thirds. You'd be looking at vertical heights in a facial third sort of way. So you'd be looking at videos. Did you hear me there, or did you lose me?
Just lost you for a second there.
So we'll be looking at ratios, upper to middle to lower third. When we spot a lower third of the face that is reduced in height, we're starting to think, okay, there's bone loss, okay, there's sagging, okay, there's, you know, facial fat pads that are being affected. But we're not thinking, if we weren't dentally trained, we would not have the knowledge to understand the impact of teeth and what's going on there. So that dual approach means that you can really think more laterally. So perfect example of your case yesterday.
It's funny you should say that.
You talk us through it. Yes.
Here it is. So, is that going to work? There we go. So this is the lovely lady that we talked about yesterday. So we've got, actually, it was interesting you say about the skeletal, because actually what happened overall, she came, she didn't like her dentures, they were loose. Yeah. I think from this you can see the lower third is decreased. Yeah. The occlusal plane is wrong, which I'll show you in a second, but I think the side-on angle actually shows it quite nicely, where actually her chin is quite protruded there. So actually I think over the course of her sort of denture, multiple dentures that she's had additions, she's had it breaking 2 or 3 times, but she's even got teeth on the dentures yet. So she's just had teeth added to it. She's actually been slowly put into the wrong position. She's actually had her chin too far forward at some point at one of the registrations, and now the actual upper incisors are proclined to meet that, and it's caused it to overclose. So I think that's just a smile one, nothing exciting. If we pull it back, you can see the occlusal plane in terms of the last standing tooth is all wrong. So that the canine there isn't over erupted. It's about 50% bone loss, and that recession is going with it. The side on shows that quite well, but you can just about start to see the protrusion of those incisors, which is because those in back lower is too far forward. We did some impressions, obviously, but then we've just got to put those in for the club. But this is my jaw registration though, so you can see the difference. Yeah. We've actually got her back retruded properly. Yeah. And I've added that little extra bit of red wax there to widen her smile. But then what we've been able to do, if we compare that to the other one, is I've brought the incisors to the right length by increasing her OVD. Yeah. And that's where we ended up.
Partial dentures, or are they complete? So you extract
complete. So that canine was her last standing tooth.
Amazing. I see.
But the previous ones she had, the 4 and the 5 were missing on the dentures and things like that. Right. But I've overlaid these before finishing them, so the eyes and nose and everything are in the right place. But you can see the amount of increase in the lower face.
Exactly.
Lower third.
You've increased the vertical dimension there on the lower face. You can see immediately that she's got much better harmony and proportion between the vertical thirds of the face, the upper to mid to lower face ratios. So that's immediately visible. And then when you really dissect and look closer, you can see the lip support is better. You can see that the chin is less rotated forward. Brilliant example. And this is an example with dentures. And this is the same sort of concept, whether we were doing some missing teeth. I mean, do you have a picture of her without any teeth by any chance, without the dentures in?
I don't. I wasn't that into it.
But, no, but if we had that, that would show even, of course, even an even shorter lower third of the face. There'd be no support. We would see very vividly the overclosure of the corners of the mouth. The downward looking corners should have been much more susceptible to things like angular colitis because of saliva buildup in the corners. So that's a perfect example from the dental perspective. And then, you know, when another reason for loss of OVD or occlusal vertical dimension is tooth wear, bruxism. And this is where, again, we think dentally and we think facial aesthetics, and you can look at this from two different perspectives and do nothing to do with injectables. But the point is understanding what's caused it so that you're treating appropriately. So there are times that just doing the dental work alone is going to, and with a really facially driven approach, is going to sort out this problem. And there are times where you need to use it in conjunction with injectables or just use injectables. So this is really where things get interesting. With bruxism, there are two things that happen, of course. We get the reduced, I mean, if it's severe bruxism such that we've lost vertical height on the teeth and we have overclosure, or we've got repositioning of the mandible, forward posturing, all sorts of disorganized.
Similar to that case, because
she was posturing forward, wasn't she, there?
Yeah.
And so in cases like that, we have to increase the vertical dimension through occlusal rehabilitation, full rehab, to regain that space to build up with definitives. So yeah, this is just where I get really excited about how dentistry meets facial aesthetics.
But obviously in the bruxism case like that, though, you're gonna have that, but surely you can have muscular changes as well, right? That's going to change
with bruxism. Yes. So often you will find that the masseter muscles have hypertrophied, and so they have enlarged, and that's contributed to a widening of the lower face. You don't always have to correct that, but if it becomes that is contributing to further bruxism, then it's an option. If it is that is contributing more to TMJ pain, and you've covered all the other bases, then that becomes an option, a good way to relax the muscles, unload the TMJ a little bit, and help with that. And then comes the aesthetic element. So there's functional and then aesthetic, and many, particularly young women who are suffering with that, and actually even in older women who've suffered for a long time and have really lost facial volume, because that happens with age, and we'll talk about that in a bit. But imagine losing facial volume in this region, but growing in this region because you've been bruxing for so many years, and then shortening this region because you've got tooth wear. There's so much you can do. A lot of the time, these patients don't realize there are so many options. So a botulinum toxin, which is a neuromodulator in those muscles, can reduce the strength temporarily, relax the muscles, shrink them, and contribute to slimming of the jaw. So, so that's bruxism. But you know, we have to be quite careful about how we treat that. If we then treat a patient purely from an aesthetic perspective and haven't addressed any occlusal problems, it's not great. And it's ideal to think inside and outside. So really it should come together. So, you know, I will always request a dental examination at the time to at least see if there's something obvious that we need to be looking at inside of the mouth. At least at the least, if we know bruxism is going on, then a bite guard. But if we notice occlusal interferences or something more chronic going on that's interfering with that or contributing, we need to be addressing that. So again, just the little examples of how the two come together.
And as you say, that's where you want to be able to offer both to your patients, to actually treat the patient, you know, holistically, completely there. We've got a question from Gareth then saying, how do you subtly suggest facial to patients of a course of treatment plan without offending them? We have it in our pre-patient sort of questionnaire tick box. And since we put it in, literally every single patient, we've got like younger skin or whatever on it. Since we put that in, like every single patient ticks it. So that's quite a good way of letting the patient bring it up when they're just sat there on a form going, don't like my smile, whiter teeth, younger skin. How do you approach it though? Because I don't do any facial assessment stuff.
That's one really good and powerful way, is that they've already ticked something to say that they're happy to discuss that. So then that's a nice, polite way to open a conversation. Say, you mentioned in your form that that's a book of concern. Let's talk about that. So that's one way. The other way is to, and I tend not to be intrusive. If they haven't brought it up and it doesn't seem to be a primary concern, they haven't noticed it, I'm not really going to bring it up. But if I really think something is letting a patient down and they're starting to ask me about, let's say they're asking me about temples, but I can see that this is an area we really need to address, then I'll say, can we perform a full face examination or assessment? But by then they've at least indicated there is an awareness of their face, and then they're willing to listen, and actually it's of interest to them. If out of nowhere I'm going from dental and they've brought nothing up about the face, I'm very unlikely to bring anything up. It's really only if they've given step one and showed me that they are aware of something, but they haven't quite got it right. That's where I say, look, let's talk about this properly and let's go step by step, and I will talk you through it. And then I can start bringing everything up.
Is that somewhere where sort of, start of my dental exam, I'll be doing an extra oral examination, palpating facial muscles and things like that. Is that something where you can sort of drop a, gentle little hint there, or is it something like that? Yeah.
So if I see masseter hypertrophy, that's really easy, because you see it, you kind of palpate it, you're doing dental examination anyway, you're then talking about bruxism, do you grind your teeth? It's a conversation starter. You're talking about the impact, you've noticed hypertrophy, you're talking about the impact of that in the lower face, is it bothering you? And that opens things up. If a patient says, nope, not bothering me, just want to focus on the dental, that's absolutely fine. And it will only be discussed if it's indicated, or if it's of an aesthetic concern to them. We don't want to fix what's not, essentially not fix what's not broken, because I think it's just a different philosophy, but that's for me definitely the way. So if it's not broken, I won't fix it. And I think with aesthetics and beauty in particular, it's not universal and it's so subjective. And if something's not bothering someone and we start to mention it, it's going to start bothering them. They're not always in a position to do anything about it. So I don't want to let that spiral into disturbance for them.
That's a really good point. So we said bruxism there. Are there any other things that, because with a lot of these sort of topics where I talk with people, it's not necessarily about the viewer then going on to do these things, but it may be that as a general dentist, it's good to be aware of these various things. So are there other dental things that we can, things like a high smile line or a gummy smile or things like that? Is that something, or what kind of things can we advise our patients about that?
So with gummy smile, there's a number of different approaches. If we're thinking about, so we're always looking at the extent of the gummy smile. Is it because the teeth are actually short? Is it because the gum has overgrown? Is it because the elevator muscles of the lip rise too high? Is it because the lip is too thin? Often it's a combination of different things. From the dental perspective, if the gums are overgrown, or if the tooth hasn't fully erupted through the gum, then we're looking at whether we can contour the gum with a really minimally invasive approach like laser gum contouring, or if we need to refer or start talking about at least treatments that involve surgical approaches. So that would be really perio specialist sort of remit for me. So I liaise quite closely with the perio specialist, and we can do crown lengthening. So that's one option. And when it comes to lip width or lip position, if it's lip width, we can talk a little bit about lip filler, but we have to always then start discussing the fact that lip filler is temporary. So we're discussing the short-term and the long-term sort of plan, maintenance. If it's lip position, because the elevator muscles are too strong, working too hard, we then start talking about modulating those muscles with botulinum toxin. And again, that can be quite short-lived. It's a great treatment, but can be quite short-lived, about 3 months or so, and can require some top-ups, but really very life-changing for a lot of people, and they will keep it up. So really minimally invasive approaches. And then if it's really too far up and the muscles are less of the big influence, then there's also the option of surgical repositioning of the lip. So a number of different avenues we can take with treating this, and it really comes down, these can be quite lengthy discussions, but we break it down, assess first, break it down, different options, and then choose the right path.
Mm-hmm, mm-hmm. And are there any other sort of more common sort of dental aesthetic parts of it that you might see and that, you know, we should be aware of as GDPs?
Yes, so we've touched on OBD. The other thing with what happens with the muscles around this area. So generally what happens with age is this. We're losing bone all over the face. Our bone shrinks. And typically we will lose bone in this region. Our tear trough area or periorbital area would become actually wider on a skeleton. So we've got less support in this region. The tear troughs get deeper, very kind of defined margins. You start to see more shadowing. As we're losing that volume as well, you get flattening of the cheek. That is contributing further to kind of less support of the lower lid. So everything's looking a bit dragged down in this region. We're losing this lateral projection here because the bone is shrinking there as well. And we start going from having this youthful sort of triangular shape to looking a little bit more parallel. Think of cheeks as the coat hanger of the face. When we lose the volume here, everything descends. So we go more and more and more parallel, and eventually we kind of become inverted. We become like this. So what's then going on the lower face as well is that our jaw is losing definition. We're losing bone in this region. We're losing vertical height because of things we've already talked about. So many things going on there from a bone perspective. Bone is shrinking, and then fat pads are shrinking. So think bone and fat pads is the support for the face. When that's shrinking, we're losing support. Muscles lose tone, ligaments lose strength, and skin texture changes, loses elasticity and thickness over time. And then we've got all the damage from the sun and all the rest of it. Mm-hmm. So at every layer of the face, there is an aging process happening. So when we think about then treating these problems or treating nuances, we need to think about the root cause, not just the symptom. So when patients present with shadowing in the lower face, typically marionette region here, a lot of people complain about, corners of the mouth look shadowy, corners here between nose and mouth, nasolabial folds we call them, get shadowy. We're looking at the root cause, and often it's loss of volume here. So the aim is to go back to what's happened, go back to the root cause, restore the volume, using soft tissue fillers where appropriate in order to give some anchorage and lift. And often that indirect approach will soften some of those lines. So you can do that sort of thing with soft tissue filler, anchoring and lifting. And then you start to think about where else you can smooth or soften some of those shadows with less filler. If we went directly to treating the lower face with filler and ignored what's going on up here, we're actually sometimes making that whole thing, that whole dimension of being fuller or heavier in the lower face worse. We need to go back up. And then this should be treated after. So that's from that perspective. But we also must always look at the side profile. And the chin plays a huge part. So where we start to lose volume around this region, and we do as well, once we start to lose volume in this region, we start to get lots of shadows. We get jowly. We get shadows just over here. And this is where really looking at chin position from a side profile, not just vertical height as we've been talking about, but where it lies in relation to the rest of the face, whether it's prognathic or retrognathic, is important, because we can, if you've got a retrognathic chin or a retruded chin, you're basically class 2, we can project the chin forwards. That then can quite nicely tighten up the jawline. We can also restore volume in the angle of the jaw and along the jawline. So you've got to look at everything from in a really systematic way when doing a facial assessment. So front view, side view, 45-degree angle, we call it the oblique angle, and make a full treatment plan about what's necessary. But usually we will start higher up in the face. We will restore deep volume loss first, and then we will fine tune. So generally what a treatment plan may look like is restoring volume loss in the cheek, restoring volume loss in the chin, so we're mimicking bone, and then we go to the more superficial layers and start fine-tuning or finishing where there are residual shadows, tear troughs, nasolabial folds, marionettes. We can look at other areas like that, but we have to think of it strategically, and also we incorporate skin into all of this. We don't kind of just look at things with one set of eyes.
That's really interesting because from like a non-clinician point of view, I wouldn't appreciate those, as you say, other layers, that sort of upstream effect that you'd look straight to here's the problem, as you say, but not actually that if you sort this out, it's going to sort the majority of the issue, and then you're maybe touching things up, or still, obviously, as you say, treating the skin because the skin is aging as well. But yeah, it's about that appreciation earlier on. Now, Emma's just asked a little question there. It's more about sort of actual physical sort of doing procedures, but being aware of vital facial structures is important. However, live patients obviously aren't always going to be the same as demo dummies or textbooks. Are there any tools for using this, ultrasound or anything like that? I don't know if you want to touch on that later or you want to go into that now.
Are we talking about complications today? I think it's quite relevant.
Are you looking for a part 2?
Happy to, if it's popular and if you'd like, and if we need to. Complications is a big subject in facial aesthetics, and I think it's important that we touch on it. It's often overlooked by both patients and clinicians before they go into it, until they're into it and they realize, and actually sometimes end up with a lot of fear around causing major complications. It's good to have a cautious approach for sure. And fear is there to protect us, and makes us more cautious. It makes us think twice, and it makes us trust our instincts when we've got an instinct not to do something. But what it comes down to is the way to tackle these fears are to equip yourself with knowledge and experience, and in a way, face your fear. How do we face our fear? We really go and look for cadaver training. We look for courses around complications. We don't dabble. We try and do, if we're going to do facial aesthetics and particularly fillers, do it well. So with Botox, the complications tend not to be sinister. They are, if they're going to happen, they are very uncommon, and they are short-lived, and they are very unlikely to cause any long-term problems. Fillers, if not done carefully, or if you're not prepared with the right training and how to handle complications, can be disastrous. So here are the most serious complications, albeit very rare. One is necrosis, which is death of tissue, death of any tissue in the body. But when we're talking about what soft tissue fillers can do, they can block vessels or restrict vessels or compress them such that there is a cutoff in blood supply to the skin. And when that ischemia happens, of course, skin can't survive, and not just skin, sometimes the underlying tissues. Depending on which artery it is, it can even affect some of the internal structures as far as the palate, tongue. And so a real understanding of facial anatomy to avoid those arteries in the first place is step one. But we have to also respect that we're human beings, and there are anatomical variations. We're not all textbook. And so even in the best of hands, these complications can happen, and understanding how to pick them up, that something's wrong, and how to reverse these complications is key. So we must always have the dissolving agent with us to be able to dissolve fillers, but often we've been trained to kind of flood the area with this enzyme to dissolve until we see the right signs that the blood perfusion is good, and then hold our patients' hands, metaphorically speaking, for a number of days, and really keep a close eye on things to make sure it's progressing to the better, resolving, not getting worse. Now we are fortunate that we have, I mean, it's been around a while, ultrasound, but I'm really hot on complications. And so I've thrown myself into lots of training around complications, but forever learning. And I recently bought an ultrasound because I do a lot of noses. Noses are quite high risk. And we're not just talking necrosis, there's also a rare complication of blindness and stroke if it gets into the more of the intracranial arteries. So we bought an ultrasound, and now I am routinely using it to scan patients, learning how to interpret these images. Essentially what it's telling us is the depth of the artery or a vein. Learning a lot about anatomy, seeing on the ultrasound image as well. It's phenomenal, to be honest. And really seeing where those vessels are means that we can use it as a guide to avoid important vital structures, important arteries. But also, if or when there is a blockage, we can target our dissolving agent a lot better, so that we're not having to flood the area and leave things a little bit less predictable. We can actually target it now and resolve things quicker. So it's definitely the future of aesthetics. I think we will see more and more ultrasound imaging as we go along in the next couple of years. Yeah, we've got it in clinic now, so I'm keen to get using it a lot.
It's like guided aesthetics, almost like implant surgery, sort of guided.
Yeah.
Planning it out.
Yeah.
And in terms, so what you said there in terms of sort of the Botox being maybe more forgiving in its complications, is that where you'd say if you're starting, you start with Botox?
Okay, so what I'm saying is I think it's great to learn both, but I'm saying that if you're going to do fillers, because the complications are more sinister, do it really well. Go on the cadaver training, really get to grips with anatomical knowledge, really understand not just the arterial distribution, but the depth of the arteries, understand what is the impact of a vascular occlusion, what are the signs of a vascular occlusion, have a good network, a supportive network around you, so that if and when it happens, you're not alone, you can seek support, because it can be a really isolating experience for a practitioner if it were to happen, especially early on. So all I'm saying is with fillers, don't dabble. With Botox, it's much more straightforward in that once you know the muscle you're injecting in and the dose you want to inject in, your chance of causing complications is very low. And if it were to happen, it's not going to be one of those sinister ones.
Dr. Essie Aesthetic says, amazing discussion, really useful for patients and practitioners alike. And Mini Shades of Fashion says, hey, can I book a consultation? So there you go. It's clearly working well for the patients. Speaking of the complications, this is one of the things that I want to ask is, how is it regulated? Is it GDC? Is it a separate body? Is it GMC? How does it work?
So at the moment,
or indemnity as well. Is there a change in your indemnity?
Yeah, so I've had the same indemnity since I started out. It's you can either have your indemnity through your dental indemnity or medical indemnity, the same one that you would for your medical or dental practice. Or you can have an external one. So you can have a cosmetic. There are cosmetic insurers now that will cover you. So there's plenty of options. It's very straightforward in terms of indemnity. Is it regulated? This industry, the facial aesthetic industry, the aesthetics industry, injectables in particular, not regulated in the UK. And basically what that means is patients are very vulnerable because there are lay injectors who are not either medically trained or dentally trained, not even nurses. I mean, there are completely lay injectors out there who are actually allowed to inject. What sets us apart is that we are still regulated as dentists. So we have the GDC to answer to. We're accountable to the GDC. We have to stick to that code of ethics, and everything that we are expected to do from a GDC perspective will still be relevant and applicable when we're doing facial aesthetics. So we are regulated in that sense, but the industry is not.
And is that true of if you're doing it within your dental practice, then you're answerable to the GDC? If you do it outside in a medi spa or whatever they want to call them, do you still have to respond to GDC at that point?
Absolutely. I think as long as we're dentists, we're registered with the GDC, anything we do is we're going to be accountable for the GDC. So we're regulated no matter what location we are injecting in. Absolutely, yeah. But the regulation is it's a frustrating subject actually, because I'm actually in awe that we aren't regulated. I cannot get my head around it. We should be. I mean, the industry should be. It is moving towards that, but quite slowly. But it is moving towards that.
Fine. So, in terms of you've mentioned quite a few different procedures that you do. Maybe just run through a few of what you said about noses and things like that. Is that sort of non-surgical rhinoplasty, that kind of stuff? Or?
So the non-surgical rhinoplasty, yes, is a really popular treatment in our clinic. Been doing it for a few years, find it very rewarding. A lot of our patients are seeking that. Noses are very niche, and I think because they're particularly high risk, there are many injectors who avoid noses. But also it takes a keen aesthetic eye to do a nose well, I think. I really enjoy doing them because I really like sculpting. So this is where I find it really exciting. Noses are a real focal point of the face, and really affect people from a really young age. So being able to treat that in a short time in a relatively conservative way with pretty much no downtime has really revolutionized the world of noses. It used to be that you just had to do surgery if you didn't like your nose, whereas now people have the option. A lot of patients just want to pursue the non-surgical pathway and will never go under the knife. And then there are some patients who would like to go under the knife, but want to try the non-surgical first. So really popular, I would do a lot of that. But nose is not a feature that you can look at in isolation. Sometimes putting filler in the nose can, although it gives a beautiful finish, and although you can disguise nuances in the nose and really streamline the nose and feminize, or in some cases, nothing to do with that, but a lot of the time feminize the nose, and in the male, with male patients, disguise bumps but still maintain the masculine angles. The point is, despite when we're doing that, we are effectively augmenting the nose. So we're adding a bit of projection sometimes. So you can't do it without looking at the chin and analyzing the balance and the harmony with the chin and the rest of the face. So nose is often treated in conjunction with the chin where appropriate. So projecting the chin where needed. And again, we don't ignore the lips. The lips, in a case where, for example, somebody's got very small lips, but you're projecting the chin, the lips can then look so retruded and really lose dominance. So sometimes they all come together, and we treat them all and create harmony there. So I love that profile balancing type of treatment. There's really a couple of ways of looking at facial aesthetics. It's either feature by feature, and often that's how a consultation begins, but then we do full face assessments. So you could break this down into profile balancing, general anti-aging treatments, which might involve restructuring or volume replacement in the cheek, sometimes treating the depressor anguli oris muscles, which are depressor muscles that pull the corners of the mouth down and contribute to a sad-looking face, and really just injecting those with botulinum toxin can lift those corners really beautifully, restoring volume in the lower face, all that we talked about. That's sort of the anti-aging side. And then you can look at general facial harmonization. So this is where nose is not particularly a concern, but you've got a retruded jaw, class 2 or class 3, by the way. You can have class 3, and that's causing the lips to look really recessed. And it gets really interesting because, again, this is where you start to look at things from, well, I start to look at things from a dental perspective as well. And we start to notice that, for example, in a skeletal class 3, we have a really good lower lip volume, but the upper lip is not supported. And so if you didn't look at the whole skeletal structure and just treated the lips, you would risk over projecting the lower lip. And it might look okay from the front, but from the side, it looks really not right because the lower lip is sat forward compared to the upper. So there are times where we choose just to treat the upper in a case like that to make it look better supported and not treat the lower. There are times where, in the opposite scenario where we have a class 2, we will treat the lower lip and not the upper. So that's what I mean by facial harmonization. So there's really a few different approaches.
So a lot of this now, it seems, is very, as you say, very much as a full face approach. Is the same as with dentistry, you say about, one tooth dentistry and whole mouth dentistry. So
yeah,
how much of it, in terms of the facial aesthetics, what you do now, how common is it that you might only do one thing, or is pretty much everything you're always tweaking multiple bits?
There are many times where it is just nose, because that is the only nuance. There are many times where it is just lips, because that's the only thing that needs to be enhanced. When it comes to facial harmonization, it tends to be multiple features. When it comes to profile balancing, it's often at least one or two. But yes, nose can be isolated, lips can be isolated, and in some cases, even cheeks. The best way to look at this is, where can we do, we don't want to do unnecessary treatment. We want to do minimal treatment, maximum impact. And sometimes it's just a very small tweak in a number of places. Really not a huge change, but because you've treated with small amounts in multiple places, I call this microfilling. Small amounts in a number of places, you have enhanced and really rejuvenated. So I'd say every case is just so different.
And do you think this is sort of, this way of looking at it, obviously you've developed this over time? When you started out, is it more sort of, or is that the way you were taught as well, that you're looking at everything?
No, things are really taught. So the first step when it comes to training, for me, it was the first facial aesthetic course involved looking at how to first understanding the behavior of fillers, understanding facial anatomy, and then it was getting familiar with the use of fillers. So we were taught how to do linear threads of fillers, and we were taught how to fill these lines, nose to mouth lines, marionette lines, and lips. That was my first course. And then, spent about 6 months, seemed to be attracting patients who just had those concerns. I guess that's because that's what I shared at the time. That's what I attracted, had lots of practice with that kind of, I would say, simple linear threads, which is kind of what you're first taught. And then realized, and it was actually at that time that facial aesthetics was just at the border of, we were stopping chasing lines and starting to go back to what is the root cause and volume restoration where it needed to be done. So I kind of was just at that time where it was transitioning into looking at cheeks being really pivotal in lifting the face. So I then went on to a cheek course, understood the impact of that. That then would tie in with the lower face treatments I would do. And then from there, I understood that the impact of the cheek would be to indirectly rejuvenate the tear trough because you're adding support. But in some people, that wasn't enough. Some people had true tear troughs that then needed treatment. I then went on to learn tear troughs. I actually at one point said to myself, I'm not doing noses. I'm never doing noses. Because I was at that stage extremely risk averse. I wanted to sleep well at night. I didn't want to worry about high risk procedures. I was very content with what I was doing, and then I would have loads and loads of requests. I threw myself into cadaver training, really understood the anatomy, did lots of reading, watched lots of procedures, finally said, right, I'm going to go on the nose training. Went on the nose training, found it really, really a rewarding treatment. Didn't dabble in it. I really threw myself into a little bit more complication management training, and then thought, well, I think I can do noses really well, and started doing noses. I'm really lucky that I have always had a really good supportive network of aesthetic practitioners. I think that's really important when you're first starting out, to build that, even if it's just one person, but somebody who's either a mentor or somebody who's your peer, who's equally passionate about it and is going to go on courses with you, is going to be there for you, is going to just support you if you're feeling in the deep end at the beginning. I think that's really, really helpful. I had my sister Yusra, she had me. We kind of went on this journey together. She was at a point where she was doing lots of noses, and that meant it wasn't really unfamiliar territory, and I really enjoyed the treatment. Found it that if you know your anatomy, you know how to avoid the complication to begin with, or at least minimize the risk. I think we can't say avoid it completely because that's just not realistic, but it's still always going to be a risk. But minimize the risk, know how to pick up a complication, really get familiar with that, and then be equipped with the right stock to manage that complication should it happen really quickly, build that confidence and feel safe, then it's absolutely fine. So I really took the approach of climbing it really gradually. As you can see, I really didn't do kind of a short burst of courses and say, right, I'm an advanced practitioner. This took years. I've been doing facial aesthetics since 2013, so very gradually.
And is there like a sort of one-stop shop course, the way that people would go onto a dip, or is there something that does it like that, or is the nature of the training that it is very much sort of bit by bit modular, sort of various people teaching various things?
At the time I did it, there were less classes around, there were less academies, and it was a little bit more of a step-by-step approach. Now there are more academies. I teach on behalf of Acquisition Aesthetics. They hold a very good foundation and advanced course on a Saturday and Sunday, of course, for just dentists, doctors, and nurses who are prescribers, which means that they already have the background knowledge in anatomy. They already have, they are already clinicians, and so they've already gone through the theory before attending the practical training. So on that weekend, they are building the skill. I think that if you do that, you still need to then go away and spend quite a bit of time mastering each element of what you've learned. And it's still not enough. That doesn't include tear troughs. It doesn't include temples. It doesn't include noses. It's so the advanced and foundation courses cover Botox for the full face, cheeks, lips, nasolabial folds, the most commonly requested treatments, and enough for you to be able to treat a patient holistically, but probably not enough for you to, definitely not enough for you to treat noses. That's definitely a niche thing, and there are master classes. So Acquisition Aesthetics also run a masterclass. Actually, my sister Yusra leads that, and I'm her co-trainer. So we're doing one in November, and we did one in July, where we teach the non-surgical rhinoplasty. That's 2 days in itself. So again, just for doctors, dentists, and those qualified. And its theory has already been covered through reading. You come in, the first day is all just more theory, anatomy, going through everything, lots of presentations. The second day is full on practical training. And even after that, I mean, it's like anything you do, it's a learning curve. And I think it's always good to have some support or a mentor as well. And Tear Trough is another masterclass that Acquisition Aesthetics do. Lips is another masterclass they do. So there, it's then broken down.
We got Aisha F saying, "I'd only trust you to do my nose." There you go. I think it was your sister did a post last week of a nose like that, and it was absolutely. Was it yours or no?
Yeah,
your sister's.
It might have been hers. I haven't posted a deviation for a while. Deviated
It
nose.
absolutely blew my mind.
Yeah,
absolutely blew my mind. It's crazy.
It's phenomenal what we can do. There's a few different goals when it comes to non-surgical rhinoplasty. You can either be just doing very simple one, like just lifting the tip with soft tissue filler by augmenting the tip. You can disguise a dorsal hump by injecting, leaving the bump well alone, but injecting above it and below it to disguise it and streamline it. Or you can correct asymmetries to an extent, correct asymmetries and deviations. We can't do what surgery can do in that we can't correct an actual deviated septum or influence asymmetries in the nostrils much, but we can influence the way that light plays on the bridge of the nose. So let's say we had a deviated bridge. It's important to understand we are, of course, we're not doing surgery, so we're not trimming away any tissue. We're not surgically removing tissue.
Additive.
We're additive. It's additive. We're augmenting. So what we're doing is then looking for areas or depressions along the nasal bridge that we can artistically and strategically fill to make it look a little bit more streamlined, but not wider. And in some cases, it is not suitable because by doing that, you'll cause a lot of width. In some cases, it's phenomenal and you can do it and achieve amazing results. Just before this live, there was a consultation and it was a deviation. And what we do is mark out with a white pencil where exactly the depressions are, take some photographs, really look from every angle and really consult with the patient about whether it's acceptable that, yes, they will have improved symmetry, but it will look a little bit wider. And it's a decision that isn't straightforward for everybody. Some will say, that's fine, I don't mind, and I've always wanted the symmetry, that's what bothers me most, and I don't mind it being a little bit wider. And some will say, no, I don't want width, I'd rather live with that kind of slimmer but deviated nose. So it's really, beauty is subjective, and that's a real pivotal an important point to remember about doing these procedures.
Yeah, and that's what Aisha F is asking again, is does it make the nose look bigger? So I guess it's not necessarily bigger, it may be wider, is it
might be wider.
Anteroposterior?
So this is a really commonly asked question, so I'll answer as well as I can. So it depends on how big it is to begin with, where we're putting the filler. So let's say we had, generally speaking, a straighter nose is perceived to look smaller. It's perceived to be smaller. But that rule doesn't always apply. If the dorsal hump is very high, to disguise it, you'd have to place a lot of filler in the radix area, which is over here in the radix. That over projection in this area can look quite avatar-like. So where the bump is far too high, it is more favorable to have surgery because it will just look too big, too unnatural, and almost not even human-like if it were done. And it can really masculinize the angles as well. We have to respect the angles in this area. So that's one contraindication, I would say, or something really to talk about with patients. Majority of the time, we're actually making the nose, it's difficult to imagine, but we're actually making the nose look smaller. And the reason is because, particularly where you have a bulbous or wide looking or flat looking tip of the nose. By placing filler in the center of and the highest point of the tip of the nose, we are influencing the way the light reflects on the nose so that it looks more central, the reflection, and that creates the illusion of slimness. So it doesn't usually make the nose look bigger. It actually usually makes the nose look smaller, but yes, every case is different. Yes, we have to assess, really discuss, map things out, explain to patients. There are times where if we think it's going to look bigger, we'll tell patient and say you're better off having surgery.
And this is where it's sort of similar to your lovely composite bonding as well. So you're playing with the light, you're sort of disguising it, camouflaging it by manipulating the way the light is reflecting off it.
Yeah, exactly.
I'm getting really self-conscious about my 3 times broken nose now.
Have you? How did you break it?
A few times.
Oh, really?
Yeah, quite a few times I got bumped around a little bit, but no, it's all good. So I'll come to you for a consultation. Well, you mentioned there about it's mainly from the sounds of it. You said about femininity is the word that's come up a lot. So is there a lot of male facial aesthetics? Is that a growing thing? Is it becoming more popular?
Definitely, a really good question. Definitely becoming more popular. We have a lot of male patients. They will have certain requests that are different. So I find that a lot of male patients are asking for Botox more, and it won't be an open thing where they're talking about aesthetics, or they're often talking about the expression of looking grumpy. They don't want to look grumpy. So that's one thing that comes up. And so the frown line is a common area that they're requesting treatment for. Often they'll say, my wife thinks I look grumpy, or my girlfriend thinks I look grumpy, or I'm a teacher and, my kids think that I'm, looking grumpy. And that seems to come up a lot. The other thing is that some men feel that older men who are in the workplace, who are competing against younger counterparts in the workplace, not so much in the medical fields that we're in, but this can be quite a thing in the corporate worlds, and they are a little bit more challenged by that. They want to look fresher. They want that they don't look older than they really are, which is something completely understandable. And then from the filler perspective, we get a lot of patients, male patients, requesting nose treatments. That's absolutely a thing. Facial aesthetics is not gender, it's not about, it's not for one, it's not just for women, absolutely not. But what we as clinicians are aware of is not feminizing the nose when it's a male patient who doesn't want feminine angles. So it's a little bit more forgiving to have a little bit more projection in the radix for a man than it is for a woman. It's a little bit more forgiving. Well, you don't want to overlift the nose in a male. Generally speaking, that can be quite feminizing. So it's understanding what is acceptable and desirable for a male face, and understanding what is attractive in a female face, and understanding those differences. Another thing is that men are conscious of tear troughs looking quite sunken. It can make them look really tired. So again, it tends to be that, generally speaking, men are coming in from the point of view of not, I want to look beautiful. It tends to be, I don't want this loss of volume in my face to reflect an emotional expression that I'm not actually experiencing. Like grumpiness, like looking very tired, and that sort of thing. Dark circles seem to be something that men request a lot of help for. So tear trough treatments are a common thing for men. When we're looking at doing cheek enhancement, so again, we talked about cheek volume. When it's lost, you lose anchorage in the face, and it's very aging. When we're looking at restoring volume in the cheek for a male, we won't do it in the same way as a female. The angles in a female the cheekbones can be higher and more angulated in this way. In a male, it needs to be a little bit more horizontal. So these are things that we have to understand as injectors, understand what is attractive for a male face, what is attractive for a female face. The tail of the eyebrow tends to be higher for women than for men. This is all generally speaking. Understanding that means that a male patient will not appreciate if we lift their eyebrows too much and feminize if that's not what they were after. So where we would choose to inject can be quite different.
Mm-hmm. I was just dropped by and said
thank you.
No, it's really so interesting that you've got to think of these different sides, and obviously as part of the training, right, you're learning those different things. That one of the things I was going to ask then is, you're saying about sort of younger people doing it younger, or wanting to look younger. Is there an age when you shouldn't be doing it? Is it better to that sort of thing with particularly Botox? You hear it's all better to start when you're younger, and is that true? What's your view on that?
I think that it depends on the procedure, and it depends on the motivation, why they're coming in, what's driven them to come. So this is a tricky one. First of all, let's say from the outset, Botox has recently been banned for anyone under 18. I don't treat anyone with fillers under 18. It's just an absolute no-no. If somebody looks young, we ask for ID. Even though they've written on, they've written, of course, their date of birth on their registration forms, but we have had to ask for ID a few times. So definitely not under 18. After 18, I really sit down in consultations and have really frank and open conversations. I want to know what's brought a patient in. And there are times where, and this is not necessarily age specific, but there are times, and very often, very young patients will come in because they're seeking treatment that follows a trend. And that doesn't, and if it's not really going to benefit them, and if they're going to regret it in a few years, for me, that's a no. But we have a really open conversation. I treat patients as if they were my sister or brother. We really have very open conversations where I talk them through the pros and cons of things rather than just saying no and that's it. Really explain it to them. With open communication like that, and with really explaining, they're on board. So nobody kind of leaves feeling rejected. They leave feeling informed, well informed, and appreciate why it was not suitable, why it was declined to have the treatment. So in short, when is appropriate to have these treatments? It depends. We have patients as early as age 21, 22 who have got signs of premature aging, sunspots, lots of premature aging because of sun damage, smokers, just very thin skin, already getting crow's feet, feeling self-conscious, being told they look older than they really are. And it's absolutely fine to have treatments at that stage. And then you have patients who have been bullied from a very young age because of a dorsal hump on the nose. They've come in soon after their 18th birthday. They come with mum, which is always quite nice because then I know that they are, it's not a must that they come with mum, but it's a nice thing because it means that they have some hand holding, that it's not a knee-jerk reaction, and they're not doing it behind their parents' backs, even though they're adults at that age and are allowed to consent. But there is that thing where it's nice that they feel supported as well. So they'll come in for the initial consultation, sometimes with the parents, and we talk through, and it's quite nice like that. Then they might come on their own for the treatment, which is fine. But that kind of vibe tends to happen around younger people, is that they want to have a parent there, or maybe the parent just wants to come along. But we're still focusing on our communication to the patient. Patient above 18 has the autonomy to make their own decisions. It's about them, but it's just nice sometimes having the parent there because you feel that they've got the right support. So going back to the bullying, sometimes they're literally waiting till they're allowed to have that treatment and they want to have it as soon as possible. And those are times where you can see the justification. So there's no hard and fast rule outside of the fact that below 18 is a no.
Mm-hmm. And is there, you say some sort of things aren't suitable? Is there like an ethical point of view, particularly with, as you say, fillers and Botox needing replacing? Is there detriment to, if you are doing it at 21, if you're doing it from that stage, is it something you're going to have to always do? Is it going to be detrimental if you stop doing it? Is it going to accelerate things? I don't know.
Yeah, no. So with Botox, actually, from an actual treatment perspective, the sooner you start doing it, the less likely you're going to develop established deep static lines that are then harder to deal with. So you should be having it when the lines, or let me say this differently, you'll get better results when you have dynamic lines but not static lines that are etched in. That's the point at which you're frowning and seeing the lines, you're raising your eyebrows and seeing some lines, but they're still dynamic, and that's where Botox or botulinum toxin works best. When they become deep and established, they will only subtly soften but not completely disappear, and you need repeated treatments, and sometimes with skincare as well, to really soften those over a longer period of time. So starting with those treatments to reduce expression lines from becoming static are better done when they are not, when they're just dynamic, so earlier on. You asked me if you start early and then stop, will that be of detriment? No. You'll probably have slowed down that process of them becoming established, so no. When it comes to fillers, I mean, if somebody came in with adequate cheek volume, young, and wants more cheeks, again, it's really talking about the why, and is it going to be of benefit? Is it going to harmonize the face? There's nothing wrong with it if it's going to harmonize. Or is it just, I want more cheeks because Kylie Jenner has great cheeks or Kim Kardashian has great cheeks? Then it's another conversation to have about, you know, trends and so on, and whether it's going to really be of benefit. So they're not all straightforward. These are just really individual facial assessments and really assessing the person's motivations and if it's going to be of benefit ultimately or not.
And is that something that's changed trend-wise? Is, you know, particularly the lips, is, you know, the big lips is the thing. Is that something is that waning off now?
Waning off.
The Geordie Shore sort of look, and you look back at series 1 and then you look at series 12, wherever it is now, and it's horrendous. Like, yeah. Is it still going in that direction?
More and more people want to have the natural look, which is great for me because that's what I'm kind of all about. I think luckily I tend to seem to appeal to patients who want the natural look, and that's probably because of what I post. Because I don't have as many of the type of patients who want to have very full lips that I'd be saying no to often. So I get lots of patients wanting natural results, which is great. Trends around lips are that actually there was a point at which everyone wanted to have really big lips, and then Kylie Jenner dissolved some of her lips. A lot of people dissolved their fillers, and it became trendy to have less lip filler. And ultimately, our ethos from day dot, literally from day one, has always been, we want to enhance, but we don't want it to look like filler. We want it to look like you were born with these lips and that they are part of you. We want, I think that when it starts to look like filler, I think it can really take away from the beauty, which defies the whole point. So once it starts to look like it's obviously filler, I think that you probably, that's when I think it's beginning to overstep the mark. So we want it to look undetectable, natural, undetectable, fit in with the face. It's all about proportion. Yeah.
Oh, perfect. And you mentioned skin. That was the other thing I wanted to ask you, because you've talked about all those other layers.
Yeah.
Now, I know Aya does a lot of skin. I know you have a lot of skin treatments done yourself. I know there are always stories on that, but are you providing skin treatments as well? And what kind of things are out there for, you know, is that the final layer of the puzzle?
It's either the final layer or it's the first layer. It depends on the situation. Okay. So in the case of, for example, where we have a pathological problem, i.e. we have a medical condition like acne, then it's often the first thing that we deal with. So let me get straight to your question. What do we do? So we do medical grade skincare in the practice. So and let me define
what is I was going to say, what does medical grade mean?
So medical grade skincare, you have over-the-counter skincare, plenty of it around, and then you've got medical grade skincare, and you've got really, there's quite a few really good medical grade brands. What is medical grade skincare? It's skincare that has clinical data and evidence to back its effectiveness. It's skincare that has more active ingredients at the correct dose to make actual changes, visible changes to the skin. And those ingredients have the right delivery to the right layer in the dermis to make changes, be it cellular changes or just changes to, for example, oil production, reducing oil production. So right doses, more active ingredients, correct delivery, and evidence-based, so has clinical trials behind it. So that's what medical grade means. Often medical grade products, they'll come in different strengths, but medical grade brands will have, because they're more active, they may have a little bit more side effects, but they are going to yield better results in a shorter time. So certainly when it comes to treating certain conditions like acne or hyperpigmentation, these should be looked at as medical conditions, therefore should be treated with medical grade products or even a dermatologist level treatment. When we start using over-the-counter products to treat to treat acne or hyperpigmentation, you're using over-the-counter products to treat a medical condition, you're very unlikely to yield very good results for the long term. Can even do more damage. So this is where I think the mentality needs to change. There are so many over-the-counter brands, but really we need to be looking at these things as medical condition needs medical treatment. So we treat acne, hyperpigmentation, a number of approaches, either through home care systems with medicated creams that tackle the cause of these lesions or suppress pigment. We look at short-term, 6-week sort of regimen, and then a long-term maintenance plan. And then we have some in-house treatments. Typically for acne, we will use the treatment I did yesterday was the Blue Peel Radiance, which is a 20% salicylic acid peel. And salicylic acid reduces inflammation, unclogs pores, just reduces dead skin off the surface. So it's chemical exfoliation. But in doing that, you are reducing one of the causes of acne. Acne is one of those things. I mean, I don't have serious acne, but if I get an episode of breakouts, I want to tackle it quickly. And acne is one of those things that can come and go, come and go. It's a chronic, underlying chronic condition. And it's not as straightforward as it being only caused by what's going on the surface of the skin. Often it is caused by, or at least there's a contribution of intrinsic factors, sometimes stress, hormonal changes, age, hormonal changes, stress, hereditary factors. Sometimes there's some evidence around diet being a factor, but it's not very strong evidence. So we treat it's more of a long-term thing. And people who have acne will know that it's something that they don't just tackle once and it's over. It tends to be something they need to look after in the long run. So we do a lot of hand-holding. We're doing step 1 and then step 2 and putting them on a regime. And once we've got over the main acute phase, we're then on maintenance. And if people neglect that maintenance, they're probably likely to come back to the acute phase.
Mm-hmm. And I think that might be what was J_Francis05 is asking, saying, would it help with blemish skin caused by acne? So I'm guessing that's saying sort of afterwards, sort of scarring or things like that. Is that part of that management-y phase, or?
Yes, I'm just looking for my charger as we speak, so I'm going to grab it. So blemishes, so post-inflammatory hyperpigmentation, PIH we call it, is what's left behind after there has been a spot. So melanocytes are cells in our skin that produce pigment, and they're extremely sensitive cells. They are triggered by trauma, inflammation, the sun, even hormonal changes, and we produce pigment. So inflammation or a spot, especially if it's been picked, then we'll put trauma as well, is likely to trigger some melanocyte activity and cause some PIH, some post-inflammatory hyperpigmentation. How we treat that is, number 1, in the case of after acne, we want to treat the acne, make sure that the angry lesions are under control, and then we start to introduce things that will treat the pigmentation. And there's a whole kind of step 1, step 2, step 3. So one of the least potent, least invasive ways of doing this is to introduce a vitamin C serum, for example. That helps to reduce pigmentation. Introducing retinoids, which will increase cellular turnover, reduce melanocyte activity, is another thing. And then, and by increasing the cellular turnover, you're shedding the skin at the superficial levels, and those pigmented layers are coming off, as well as renewing the skin cells. And then there are pigment suppressors that we can either give you at non-prescription strength or prescription strength. And at prescription strength, we want to then be monitoring closely their use. They're not used for the long term. They're used for sort of about a 6-month span of time. And then as you're weaning off them, you're doing it with, again, sort of gradually weaning off them. May need to reintroduce them again if you get pigmentation again. Because as I said, pigmentation is triggered by so many different things, and it can be something that comes and goes. So yeah, yes, we do treat that as well.
Mm-hmm. Someone's saying that your skin looks amazing. And what treatments have you just done? You're saying about
yeah. So you saw, so my story, I did the Blue Peel Radiance yesterday. I am wearing makeup though. Let's not forget that makeup can cover pigmentation. I have some pigmentation here. Profilo is another treatment that I really like. So Profilo is an injectable treatment, and you're introducing, it doesn't restructure your face at all, but it rejuvenates skin and texture. So it's like an injectable moisturizer. So we inject it in 5 points on the right, 5 points on the left. And it's 2 treatments, 30 days apart. And what it's doing is you're injecting a bit of hyaluronic acid, The hyaluronic acid is providing moisture, but it also has a bioremodeling technology in it, which is patented. And what that does is it encourages type 4 and type 7 collagen formation. And these two types of collagen are responsible for how your dermis and your epidermis are connected together. So where you have crepey skin, dehydrated, fine lines and wrinkles, quite textured skin, that union of epidermis to dermis will help to smooth out some of those wrinkles. So Profilo is a big yes for improving texture and hydration. And I'm just going to grab my charger. Where is it?
Go for it. Go for it.
I'll take it with me.
Really a tour of the practice now. Guys, if you've got any other questions, please do pop them in. First one up there is, how about secret? I don't know if that's something.
Secret?
What subject is more important, evident in dental school? Chemistry or physics? Chemistry, definitely. Although that's not really what we're chatting today. Or both. We're going for both. Although type 4 and 7 collagen, that took me back to second year with a bump. Do you recommend the Profilo in young people? So coming back to that sort of side of it again, is that something that you could be doing from a sort of...
How young? So again, not under 18. Above that, if it's indicated, so if you've got very dehydrated skin, if you've got very crepey skin, in other words, fine lines or wrinkles are showing, then yes, you can. I've got patients in their early 20s having Profilo nowadays. We are using more SPF as a nation, I think, but there is still a lot of sun abuse, I think, and there are still a lot of people with premature aging, and it is beneficial. It's what's nice about it is that it's rejuvenating the skin, but you don't have much downtime, generally speaking. Of course, there are risks with every treatment, but you're not restructuring or changing your face. It's not like fillers where you're plumping, changing the lips, changing the nose, changing the cheeks. It's not going to be one of those very obvious treatments. It's literally just a rejuvenating the skin type treatment.
Mm-hmm. So it's more sort of replenishing or topping up what should already be there, essentially, rather than trying to alter any structures.
Dr. Amara asks, can Profilo treatment be used if on Accutane? No. So when on Accutane, you shouldn't have any fillers or injectables. The skin barrier is often impaired when on Roaccutane because, of course, as you know, the skin cellular turnover is so active, and often you're shedding skin and peeling such that there is an impairment in the barrier. So there's a higher risk of infections if you're having any injectables when you're on Roaccutane. So that's a no.
This is what I'm going to need to have like ire on as well or something. But are there instances where hydroquinone doesn't work, for example, on a smile line that has hyperpigmentation? I hope you know what that means because I ain't got a clue.
Are there instances where hydroquinone doesn't work, for example, on a smile line that has hyperpigmentation? So hydroquinone is a pigment suppressor. It's prescription strength. There are times when hydroquinone doesn't work if the pigmentation is very deep, or if the pigmentation is of the hereditary type. It can be the hardest to tackle. Often with smile lines, if it's localized and you've got pigmentation around there, it's probably happened because you've had a deep fold. And that area has therefore had a lot of friction over a long period of time. That friction has triggered melanocytes and you've darkened that area. And usually we would expect to see good improvement with hydroquinone. But if you have residual pigmentation, despite being on hydroquinone for a decent length of time and a good course of treatment, then there are other options in the way of deep peels. I don't do a lot of those very deep peels. So I usually will yield good results with hydroquinone. Where I haven't, I will refer to people who do a lot of those very deep chemical peels routinely.
So secret is a microneedling procedure. So what's microneedling?
Okay, so I think you're talking about the Secret Pro. Microneedling is a treatment that involves the introduction of very small little needles along the surface of the skin, often in kind of a gliding motion or a rolling motion. And these introductions of little needles on the surface of the skin induce a bit of trauma, which then induces a healing mechanism in the skin to stimulate the production of collagen. And it's useful for many conditions. One would be acne scarring, for example, where you have pitted scars and indentations in the skin, or just lax skin where the production of collagen will help tighten the skin, fine lines and wrinkles. So microneedling is a very popular procedure. We do microneedling in the clinic. Microneedling can be just microneedling, or it can be microneedling along with radiofrequency. Radiofrequency is then providing heat as well as that physical trauma to the skin, and that heat further stimulates collagen formation. So when combined, it can be very, very effective.
It sounds really comfortable, lots of little needles. They've got another one about, is there a risk of rebound pigmentation with deeper peels?
Yes. So with deeper peels, if you're having you can't have a deep peel without having been on hydroquinone for a length of time, because the very deep chemical peels will inflame the skin, and then you're more likely to have post-inflammatory hyperpigmentation. So nobody would ever do a very deep chemical peel for you unless you've been on hydroquinone first. Because the hydroquinone will have suppressed your melanocyte activity first to prevent the risk of, or at least reduce the risk of rebound pigmentation. But is it a risk? Yes.
There we go. I think we're going to get you and I onto this, do like a skin masterclass, because it seems like everyone wants to know about. I don't know if we've got any last question. I'm conscious that we've left Ahmed alone with the kids.
He's really good at putting them to sleep, but sometimes they can run riot around him, so around me as well. So yeah, I think I saw him pop in, I think, at some point, so that's a good sign. But yes, I'm amazed we've managed to speak for 90 minutes. I'm just scrolling up to see if there's anything risky. Yeah, that's a good question we've answered. I think we've covered so much, Rupert.
We've done well. We've done well. I thought we've covered maybe too much for our part 2 episode, which I'm keen for. We've got a few more then. Is there anything you can do about redness caused by tret? What's tret?
Tretinoin. Tretinoin is a prescription strength retinoid. It has to be prescribed. And essentially what retinoids are doing, they're increasing cellular turnover. And so what comes with that is sometimes you will see redness of the skin. It's a perfectly normal side effect of using tretinoin. And some of that early irritation you get in the first 2 months can be quite annoying and put people off, worry them. You get a little bit of redness, you get peeling, flaking, soreness, sometimes a bit of tightness. That is all a normal part of using tretinoin, and it's an indication that retinization has begun to happen and that your cellular turnover has begun to speed up, which is a good sign. Usually by about the 2-month mark, that all settles down. Now, if you have too much redness such that your barrier is quite impaired, then you should stop using tretinoin for until the barrier repairs, and then use a really good hydrating cream that has ingredients in it that are going to repair the barrier. And I always recommend the Obagi Hydrates. It's got in it hydromanol, which is a humectant, which will hydrate very well without occluding the surface of the skin. And it has mango butter, shea butter, and avocado in it, which are really good for repairing the barrier. So you just want to be using something like that. If you don't have Obagi Hydrates, CeraVe is a really good moisturizer as well that you can buy over the counter to help with redness. But the key thing is stay off your tret and all active ingredients until the barrier is repaired. You haven't got as much redness, and then you can go back to it. And when you go back to it on a more sort of less aggressive protocol. So use it maybe 2-3 times a week rather than every night.
Love Cakes Wembley's asking, what was the price of the radiance treatment you had yesterday? How often should one get it if you've got normal skin, no major issues?
So the Blue Peel Radiance is £90 per peel. We're actually doing a promotional offer at the moment of 10% off for the coming month. But I'm going to announce that on the Instagram, the story at some point in the coming week.
Exclusive. We got the exclusive.
Yeah. And if you've been if you've been on this live and wanted to have one, then send me a DM, because then at least you can get booked in sooner rather than later. The diaries get quite full.
There we go.
Yeah. How often should one get it? Yeah. If you've got active acne and you're really trying to tackle that, I would say every 2 weeks until that angry acute phase of acne has reduced. If you're doing it for more of a maintaining acne that was acute, but you're just trying to stay afloat with it, once a month will be fine. The other thing is that some people just do it before an event, so because you get glowing, radiant skin after 2 weeks. So if that's the case, just make sure you do it about 2 weeks before your event.
So I should have come and seen you before the Aesthetics Awards. That would have been,
yeah.
That would have been the one, wouldn't it? What was the other one? Lots of questions on acne. We're going to have to just do a special acne episode, aren't we?
Yeah, we should get Aya involved. She loves that subject, Dr. Aya, as well.
Yeah, absolutely. I was chatting to her about it. And she wanted the same thing about talking about dentures as well. What's a good regime for example, microneedling, etc., for someone with acne? So, like, how do you approach it? Is there a sort of, obviously not a one size fits all, but do you sort of start with something and then move on?
Yeah, what we would prefer to do is when you've got acne and you've got acne scarring alongside each other, which is a very common scenario, it's better to treat the acne first, at least the really angry phase of acne, reduce that those infected, the very angry lesions, because if you've got very kind of active pustules and then you go over it with microneedling, you're effectively spreading all of that around. So it's better to reduce the inflammation, reduce some of those causative factors, at least on the skin. Make sure your skin is well exfoliated, unclog your pores, reduce that inflammation. You may want to be on at least a topical antibiotic cream or a bacteriostatic cream like benzoyl peroxide. Just get all that angriness down, get that acute phase down. Once that's happened and you're then dealing with post-inflammatory hyperpigmentation and acne, and acne scarring, so pitted scars, that's the point where microneedling is going to be more helpful.
Moving on from the acne, we got, can you use retinol on your under eyes and on eyelids?
You have to be quite careful with introducing retinoids in this area. This is an area of the face that has it's the thinnest skin region of the face. More likely that you're going to get more irritation if you introduce raw retinol in this region. Definitely tretinoin should be avoided in this area. What will happen is that you get lots of redness, lots of peeling, potentially even cracking of the skin. You don't want to have too much inflammation around this region. You don't want to have post-inflammatory hyperpigmentation as a result of that inflammation. And then that is then harder to treat in this region. So we have to be very cautious. What you can do is use some brands, medical grade brands do encapsulated very low doses of retinoids, but they are encapsulated properly. So it's an eye cream that has a bit of retinol in it. That is suitable, but be careful with using a raw retinol in this region. Don't do it. Keep to the periorbit, so keep to the orbital margin, which is there. So that's the margin where your socket begins. And know that that's your boundary. It's still going to spread a little bit, about a centimeter below, beyond that boundary anyway, underneath the skin. You can't see that happening, but it's doing that. So you may get some benefits anyway, but let that be the boundary.
Perfect. Journosaur Francis likes the sound of the offer. How can she book a consultation in with the clinic?
The best thing is to call the clinic directly tomorrow. I will pop the number on my Instagram page over there. If you just press call from my Instagram page, it will take you straight to it. And if it's specifically to get the blue peel radiance, drop me a DM, because I can, because you've been on the live, I can sort of contact you to get in the next few weeks, because the diaries get quite busy.
Yeah, I see the live's like the new hot offer. We should have announced this, shouldn't we? We've got one more there saying, how about super black under the eyes? Sorry for asking so many questions. I mean, I could do with a bit of that. I struggle with that.
Yeah, under eyes that are dark circles are the hardest to treat, and it's important they're hardest to treat, but they can be really improved by a number of things. It's usually multifactorial. That's the first thing to remember. So why do dark circles happen? Number of things happening. So it can be because of loss of volume in this region, which is something that happens with age, and in some people happens faster than others. Some of us are born with not very thick fat pads in this region, and so it's hollow from even a young age. The point is that hollowness is acting as, imagine a bucket. It always looks like there's a shadow inside a bucket, because emptiness means that there's going to be a shadow over it. When you play, and if it's in the case of hollow tear troughs, the placement of volume through soft tissue fillers will plump up the skin, make the light reflection better, reduce some of that darkness. But it's often not a one-size-fits-all approach with this, because it's not just because of loss of volume that we have dark circles. It's sometimes just because of very thin skin that shows the reflection of dark muscle, dark vessels underneath. That can sometimes be improved with soft tissue filler as well, tear trough filler, because that filler is then acting as a barrier to reduce some of that show through of that anatomy underneath. So that's one thing. And then one of the other common cause of dark under eyes is pigmentation. Pigmentation can either be because of sun, can be because of inflammation around this region, eczema, or it can be because of genetic factors. If it's the genetic type, that is the one that is hardest to treat. Some of these questions are better probably so it depends so much on the situation. Generally speaking, I am very careful about allowing very active ingredients under the eye in a raw format. So hydroquinone, I usually don't advise my patients to put hydroquinone under the eye. We will still use it just up to the orbit, but we often see some improvement under the eye because it will travel to some extent and spread underneath, but you don't want to put it raw in this region because it will irritate the skin. So if it's a case of pigmentation, sometimes vitamin C will help. With vitamin C, we still encourage it to be just there, but if you are used to using vitamin C over a long period of time, vitamin C serum can slowly be encouraged a little bit further up, but you must stay away from the lash line. There are some non-prescription strength pigment suppressors like arbutin that can be used around the eye. There is a product called Tebi Skin that we stock in the clinic, which is a nice one for pigmentation. We have seen some success with that, but it takes quite a while for it to yield results, several months. Another good thing for under eye dark circles is mesotherapy. So quite a few options, but best to have a consultation.
Perfect. Right. I think we need to do a skin episode. We'll get
no, I'm talking endlessly about skin, and I know our main audience is dentists, and I think we mainly have patients here now, but I hope it's been of benefit anyway. So
no,
yeah,
absolutely. Well, let's wrap it up because I think Ahmed's going to be overwhelmed now.
Yeah.
So and he won't let you back on again, or he won't want to come on himself. But that one's coming soon. So I like to finish them up with the same sort of question. Now, it doesn't have to be facial aesthetics related, but just sort of like a top tip for young dentists or facial aesthetics practitioners. But I know, what's the one thing that you sort of do now or know now that you wish you were doing a little bit earlier? And I said, it doesn't have to be facial aesthetics. Not that we've spoken about bonding or anything tonight.
I think my message to young dentists is, you can choose any path you want to, but explore all options and walk before you run so that you never feel overwhelmed or in the deep end, isolated with complex cases you can't handle. So walk before you run, but don't be afraid to pursue things. And the way to do that is to just get on to training. When you see where your passion lies, get onto the training and pursue it.
Perfect. And then do loads and loads and loads and loads of courses that you could.
Loads. Be a course junkie. Yeah.
Thank you so much. It's an absolute bumper session tonight, and we'll definitely have to get you back on for the skin masterclass.
Thank you so much, Rupert. It's been
my
great
pleasure.
Chatting. Thank you for having me on. Really appreciate it.
Cheers, guys. Thanks everyone for stopping by, and see you soon.
Bye.
Bye.